to spend the next little bit talking specifically about things that we use commonly in our practice, often for androgenetic alopecia, but sometimes in conjunction with other things for combination therapy. So Marc, you remember the evolution of really when Minoxidil and Rogaine came out, and we don't really understand the mechanism of action perfectly. We talk about, vasodilation. Talk to us about your use of Minoxidil in practice. Our closest friends are, she's actually the nephew of Ginter Khan, who was the one who discovered that systemic Minoxidil, when it was being given as a blood pressure medication, actually grew hair, and then formulated this topical formulation and went through many permutations of patents. And now I've gotten to know his daughter is still around, Michelle, and she's a good friend of ours too. And that really has changed so much of what people do, but that dates back 30 years ago. So talk to us about Minoxidil topically.
So I think the biggest challenge with Minoxidil is because it's been around for 30 years and there's so much discussed on social media about it, on internet chat rooms, education with patients. So a couple of points I make to patients. It's not a prescription. It hasn't been a prescription for many years. You can get it over the counter. So I point out to them, when you look at the insert, it's going to talk about just the vertex of the scalp. And I tell them that's regulatory from the FDA, that it works in the front and back, because people sometimes come and said, I've been using it in the back and I'm losing it in the front. Well, why didn't you use it in the front? I don't know. Didn't say it. No one ever told me. So tell them it works in the front and the back, because people will read the insert. It is worth looking at what patients will see and explaining what you think. So front and back, I tell them once a day. I say it's going to say twice a day. And I tell them most dermatologists say once a day for efficacy. And I think the most important thing of all is the time frame. At least 6 months, really more like 8-9 months to begin to judge this. I can't tell you how many people I've seen over the years that just label Minoxidil, Rogaine, a failure because they did it for 1, 2, or 3 months, didn't see the difference, and they stopped it. I explained to the patient, we can't see it that quickly. Maybe some people, but they're lucky. Most people, it's really 6, 8, 9 months to see that difference. So I think a huge part of this is education. And then depending on the type of hair someone has, to talk about whether or not to use a foam version or the solution, which one is better for that individual patient. I think the main thing is, I tell them, if you can get to 8, 9 months and you see a difference, it will be very easy for you to do it after that. Once you see a benefit from this, background noise, you won't even think about doing it. But the hard challenge is to get past those first 8, 9 months.
So there are oral therapies. Similarly, yes, there haven't been a lot of advancement in that. Cheryl, can you talk to us about your experience using Finasteride, Propecia? And then also, if anybody else wants to touch on some of the current thought processes in terms of what we're concerned about, and people are calling sort of the post-Finasteride symptoms, or syndrome, where people may have psychologic issues that may be actually in higher incidence for people who take that, or erectile dysfunction type issues. So Cheryl, let's start with mechanism of action and explain a little bit about androgenetic alopecia in men, and then how Finasteride actually works.
Yeah, so Finasteride, which was one of the first oral FDA cleared oral therapies, it inhibits DHT, and we know that that's kind of the main component in men. But for the most part, they noticed that with Proscar, that men who were taking it for benign prostatic hypertrophy saw that their hair tended to grow, and that was kind of how that developed. A 5 milligram Proscar titrated down to like 1 milligram was what they settled on for Propecia, which was the preparation that came out. I have a lot of men on this product, and unless they're just not fessing up to me, I don't hear about any impotence or any decreased libido or anything like that. So maybe because I'm a woman, they don't want to tell me, but I have not seen the incidences that they are talking about. And so that's one of the first questions that, my Google search people will see. And I just renew it. I probably see them every 2 years, and I ask them every time they come in. And the good thing about it is some of the patients, especially my Black patients who have a higher incidence of benign prostatic hypertrophy, that keeps their PSAs good. And so I have not had any complaints about that product, Dutasteride, any of them, where, the Google searches show all these side effects.
So, Reena, talk to us about your experience with some of the new supplements out there. And, I know that there's multiple different scenarios of supplements. You have the Viviscal and the Nutrafol, and then some people like us, we carry Votess in the office. There's been actually some recent investigation into key ingredients in terms of some of these products. And it turns out that there's quite a bit of controversy about biotin, which we've long been recommending to people, but over the past 6 months, we've kind of halted that. So what do you like to look for in your supplements for hair growth? Do you sell them in your office, and how do you advise your patients?
Well, I too have a lot of patients on finasteride, a lot of males, and they do quite well. But since it is the #1 Google topic, people already come in knowing about it. A lot of patients are very resistant to starting it in the first place. I do try to tell them my vast experience has been overall very beneficial. I don't have a lot of downsides. Every male member of my family takes it and they do fine. Most of them don't complain to me, at least about certain topics, but I think they're okay. But in the patient who's very resistant to taking anything pharmaceutical, I do think that I might have a skewed population, because I do have a patient population that tends to have more proclivity towards the more natural and the more supplements. And so I do like to address them. I also carry Votess in the office. I personally like it a lot because it actually doesn't have biotin in it. I think that there was a lot of controversy with the lab interactions and with making thyroid tests look abnormal. And I tell people, look, if you can always hold it before a thyroid test, but you can't hold it before a heart attack. And that is something that's potentially very dangerous and devastating. And if it were really beneficial for your hair, I think I would have you keep taking it. But since we really don't see a lot of data that it's beneficial for hair, and we see that it's potentially deleterious, I don't think it's one that we should continue to recommend for the vast majority of patients. I like Votess. I do think it has a good mix of ingredients. It has the ashwagandha extract and the soluble keratin extract. And it also is kind of nice because it's one supplement to replace a lot of supplements. I do think there's a little bit of supplementitis going on in the US, because there really is a supplement for every single thing. We used to carry Viviscal in the office. I think that it's very easy to get online, so I don't feel compelled to carry it. Not because I don't like it. I think that, for certain patients that aminomar protein is beneficial. I find that if they're very intense shedders and I feel like there might be a dietary component to their hair loss, I might recommend that as well. And then Nutrafol I like because it has and Votess, the male supplement, they both have saw palmetto in it. And that's kind of a good natural alternative, a natural DHT blocker. I do tell them, well, it's not going to be as efficacious because it's not as strong. It's a more herbal supplement. But then if you're very, very wary of adverse effects, then it might be something that you could choose to ease into it and see how far you get with that. To me, those are the big three. I do think there are a million hair loss supplements out there. It's a very big market, but I do like that the effort that these companies put into looking at the ingredients. And I think that patients have had good varying success with them.
So Cheryl, you mentioned that Dr. Keeney taught you so much, many years ago, and that in some cases you treat certain conditions the same. I think that mention of biotin is really important, potentially altering your thyroid function tests and potentially altering your cardiac workup. So for your patients that have been your patients for many years that are on biotin, how do you have this discussion? How do you do the intake, and how do you counsel them about this?
Well, first of all, when I'm doing a workup, when I'm drawing all the labs, I usually have the biotin levels, the B7 looked at. And most people are off the charts. They're totally off the charts. I'm like, well, you don't need any more B7. Just slow down on that. But I noticed that, yeah, people will say their nails grew very nicely, but the hair, nothing happened with the hair. So many years ago, I kind of stopped it because of also other changes that you can see. What I tend to do is put people on vitamin D supplements. And I found that I could convince a lot of my, especially Black patients who were vitamin D deficient in the first place. Most of them have a vitamin D level below 30, that I need to supplement them anyway. And when I find that I do supplement them with vitamin D, I find more hair growth. So that is what I try to explain to patients, that I see more benefits with vitamin D than I see with biotin. And most people are like, oh, okay, well, I'm not doing that. So that's what I'll do now. And it's kind of easy to get them off of biotin because they've been on it for so long and they can see it's not working.
So Marc, I want to talk about PRP, and I want to go to you, and then I want to go to Reena. So first, you wrote one of the original articles about PRP injections for alopecia. You've been doing this a long time. You obviously do hair transplants that we'll get to. So talk to us about really the evolution of PRP injections for the scalp, and really how you started doing it, how you became interested, how you measure improvement for these people.
Right. So PRP has been done in medicine for many years. You know, across the street from Cornell Special Surgery and orthopedics have been using it for 10, 15 years for all kinds of orthopedic injuries. First time I heard about it was when A-Rod on the Yankees had a hip injury in about 2003, 4, and he went to Germany to get this new treatment, and it was PRP into his hip. So it migrated in dermatology 5, 10 years ago. How I heard about it was one of my ex-fellows, Meena Singh, called me up and said, Marc, this PRP for hair is great. I've been doing it. She's in Kansas City. I've been getting great results. Definitely go with it. I totally trust her. So I started doing it. I, as always, lowered the expectations with patients. I said, let's try this. I think it's safe. It's your own product. It's been others' medicine. The protocol is still not standardized. It's not like fillers and Botox, Joel. It's not, there's no standardization, but I think the consensus is to do at least 2, 3, 4 treatments at the beginning to boost the cycle, and then maintenance. Some people do it 6, 8, 9, 12 months after, if it works. I do it once a month for 3 months, and then reassess the patient at 9 months. Our experience has been, we track it, about 70% of people who we've done go on to do maintenance treatments. So I overall very happy with it. We've had very low side effects, very little side effects with it. And I think 70% is pretty good. I mean, I tell people going in, 1 out of 3 people spending the money for PRP not seeing results, that's going to happen. That's a pretty high number. But if you tell somebody that it's not going to work 100% of the time, you tell them, I really think most people are very happy with it. I think one point I'll make, just a lot of times people say that's so painful. Again, I numb scalps regularly for surgery. It's no problem to numb the scalp, but I'll tell you, pain is not an impediment for most patients. Most people do quite well with the pain. We use either vibration, which is what we've been doing a lot during COVID, because what I used to really love doing is the Zimmer cooler that's on the Fraxel to cool the skin. And that does the trick. But with the COVID, I don't know if we want to blow it around the room. So we've been using vibration, make it a nice relaxed atmosphere, talk to the patient, tell them it's going to hurt, and people usually get through it just fine.
So we also have historically used the Zimmer chiller. That seems to work well. We have a Pronox unit in the office, and very rarely there's somebody who wants to inhale, exhale, and feel like they've had 4 or 5 cocktails. You know, there are times where somebody actually likes the Mesoram needle, you know, where multiple needles hit at the same time, and it just makes the treatment more efficient. So I want to turn to Reena, because I know you have one of the busiest PRP practices in the country. It's a lot of what you do. And from the mechanics of how do you decide what company to use? What are the things that you look for, you know, in terms of platelet yield and inflammation and overall, does it come with the centrifuge or cost or those types of things? And then some people actually look really closely and say, where is, the unit made? So, some of these units we know are made in China, and there's some people who really at this point are looking for, countries where something is manufactured that's consistent with good clinical practice inspections, actual inspections like they happen in this country. So I know that Regen Labs is made in Switzerland and Eclipse is made in Israel. So take us through, from a busy practice, how you think about PRP and how you actually do it and the mechanics in your practice.
So I fell into PRP and hair loss rather serendipitously. I started doing PRP. I think there was a rep in my office describing it to me, and then I talked to another couple of physicians. And so I started doing it fairly early on, probably not as early as Dr. Avram here, but fairly early. And the company I started with was Eclipse. It was just the one that seemed to be the first to market. It was the first I'd heard of. And I started getting good results with them and didn't feel a compelling need to change. However, if you're doing a lot of it, you should always look at something critically and make sure that you are hopefully providing what's best for the patient. And I think at the end of the day, it's something that's very difficult to assess. I think that a lot of the studies where they measure platelet counts, there's a little bit of bias involved because it might be funded by this company and try to skew the results against a certain company. And so you have to really be a little skeptical when you look at those results. I think at the end of the day, when I look at my patient's results, I feel very satisfied with what I'm using currently. And again, don't have a compelling reason to change unless I see something that's very, very strong against it. But I do know that one of the companies, I don't know if it was Helion or something, but Helion, they kind of shut down because their factory in China wasn't really up to par. So I felt very comfortable with the standards and with the sterility and everything that I have found with the particular company. But I do think that you have to pay attention. You have to make sure that there is a robust number of patients that have been treated with a particular system. There might be a new kid on the block, but you don't know until you've treated thousands and thousands of patients if there's going to be some contaminant or something. So for me, a company that's been around for quite some time, and if they have, a good safety data with really, I knock on wood here, but we really, really don't have a lot of complications with it. Infection is almost unheard of. And, apart from just a little bit of tenderness after the treatment, patients really do well. I think I've had one person in all the many, many patients I've treated who felt like he had tiny bumps afterwards. And he himself realized it was because he was applying the scalp oil that he had gotten online. And that was really the culprit. It wasn't the PRP at all. I think that it's nice to get a company that has, where you can buy a certain number of tubes and maybe get a centrifuge along with it. So you don't have to buy this very expensive machinery. I am very fortunate that I have centrifuges in quite a few of my rooms just because I have a busy practice and I like to be able to have the turnover and the flow the way I like it. So I have been very fortunate to be supported in that regard, where if my volume has increased, I've been able to have more centrifuges. So I do think that those are very important. Is the company able to support you? Are they able to provide, extra centrifuges if you need it? If you have a tube that happens to have a mishap, will they replace it for you? No questions asked, which I've had that experience with the company that I use currently. And so I've been very happy. I do look forward to a time where there's some maybe just independent analysis of platelet count and platelet capture that, in my opinion, is more unbiased than some of the previous ones. And so hopefully that will continue to happen. I think as far as some of these orthopedic surgery uses, a lot of them are out there saying, well, we have higher platelets. I do believe the data that shows that there's also a higher component of inflammatory cells involved there. And some of the studies that have compared some of the double spin versus single spin systems have not really shown a benefit to the double spin systems. And those are very cumbersome for a derm practice anyway. So I feel like we're getting good benefit with an easy system to use. It's pretty user friendly.
So we started in my practice About Skin in Denver in September of 2016. And that's right around the time where actually the Cleveland Clinic, which is one of the biggest hair disorder clinics in the world, started using it as well. And in that video clip that I saw on TV, they had the Eclipse system and you could see it right there. So that really sparked my interest. And then, being a data person, I really looked through the literature. There's been an article by Corsani and Jad that looked at androgenetic alopecia in women that used the Eclipse system. Similarly, a protocol validation from Amelia Hausauner in dermatologic surgery that uses the Eclipse. And then, there's experts out there like Gordon Sasaki, who's got an in-press publication in Aesthetic Surgery Journal. So, that's been our experience, and we use it generally for androgenetic alopecia, and people have had a good experience. And I think, some of the same things that you mentioned. So Marc Avram has been training fellows and doing hair transplants for many, many years. And as we know, Dr. Burgess said that she's been doing transplants for many, many years. So Marc, I think, if people try PRP and they're not successful, or if people just want to go right for the real deal and see improvement, talk to us about really the landscape of doing hair transplants, the mechanics of how you do it in your office, the systems that you do, and really what you currently do, state-of-the-art transplants. Cheryl mentioned people doing punches many, many years ago, and now follicular units. So
Right.
You are the hair transplant guy.
Right. So hair transplantation for any dermatologist is a logical extension of what we do. It is purely dermatologic surgery. It's cutaneous. It's local anesthesia. We're very comfortable with local anesthesia. So it's a procedure that's right up our alley to do. I'd say probably the biggest practical challenge is really, for most dermatologists, just finding the time to do it. It's a procedure. What's different than most dermatologic surgery procedures, it's a procedure that's measured in hours, right? And that's with an efficient team. I mean, a quick procedure, a short procedure is 2, 3, 4 hours, and a longer one is 4, 5, 6, 7 hours, right? And some of my colleagues do even longer procedures. So I'd say it's something that derms should do. It's local. It has a very low complication rate, very low infection rate because the blood supply is so excellent. Surgery is consistently natural. There's 2 ways we do it. The donor dominance with Dr. Ohrenreich, in 1959, published with the large batch. Actually, the original studies are from the 1930s from Korea and Japan, but didn't make it to the West. And it really wasn't pursued in Asia either. But so I'd say 59 is the modern era of hair transplantation. And they did large plugs from 1916 to the mid 90s. In the mid 90s, they basically literally said, why are we doing multiple follicular units in plugs? I mean, scientifically it grew, but sometimes it looked pluggy, doll's hair. So what we did is we evolved to taking a strip, which is basically an excision, and then dividing them into follicular units. We still do that regularly. Tomorrow morning, I'm going to be doing elliptical dermal harvesting surgery. In women definitely prefer that because of the following reason. You don't need to trim hair. If you do follicular unit extraction, which has become quite popular, probably the majority of harvesting is now FUE, you have to trim the back short. So in men, if you ask me to trim my hair short in the back, not such a big deal for you, Joel. But if you ask Reena or Cheryl to trim their hair to 1 millimeter in the back, that's a bigger deal to have the hair grow back. And the scar from a donor ellipse is of no practical concern if you're not going to wear your hair short. So for a woman, that scar is meaningless. So we do ellipses. In most men that wear their hair shorter, we're going to do FUE. I happen to use a robot with it, but you can do it manually. And there's a whole bunch of amazing mechanical device-assisted FUE techniques can be done. So what you do is you numb the back with local, you go directly and take out each FUE, high hundreds, low thousands at a time. The incisions are 0.8 millimeter. So Cheryl will tell you, like years ago, they were 2, 3, 4 millimeter punches. Now we're doing 0.8 millimeter punches. And that's the beauty of it. So the incision is so small, we just put Aquaphor on back there. It heals in about 4 or 5 days. The scarring is just pinpoint white scars, really no aesthetic issue if you wear your hair short. And then generally we work in the frontal part of the scalp. This is a general statement in the frontal part. As I said, one other challenge is you can't do it alone. You need assistance that you train. I enjoy it also because you get to know people over a few hours. We watch a movie, we talk, try to keep it really relaxed. We take a break, we eat, so it's nice and comfortable. They go home, there's local wound care, and it grows in, just like medical therapy, 8 to 12, 14 months. So I'd say it's overall, when people, yes, somebody, I did a consult and said, Dr. Avram, what's the percent a transplant will work? That's 100%. I never say 100%. Nothing's 100%. I say it's in the 90s, you know, and I'd say the biggest thing to tie in what we've been talking about with surgery, the biggest thing by far is that, and the point I try to make to every patient is that surgery will restore density. It will not stop your ongoing hair loss. So again, back to when Cheryl and Reena were talking about how the history and what they're on medically, if someone comes in, they're losing their hair, and they say, I'm going to skip all that medical therapy, I just want you to do surgery, and it grows in and they keep losing more hair, they're going to come back and say, I don't see anything, it didn't grow because, well, they've lost more hair. So really to tie it together, surgery can restore, surgery can thicken areas that medicine can't, and it's a great procedure. But really the true home runs, you know, I'm wearing the Yankee cap, the real home run into the upper deck is successful medical therapy with surgical therapy. That is the home run. If you can stop the hair loss and then add, that's when you get like really amazing results. If someone's trading hairs, it's still worth it, I would argue, but somebody has to realize that's going to be less obviously cosmetically impact long-term. So
That's a great point. And honestly, there's been studies looking at the synergy between PRP with
yes,
Minoxidil, with Finasteride, and really that whole comprehensive package. Cheryl, talk to us about your hair transplant practice and how the mechanics work in your office.
Well, I'm not doing hair transplants any longer. I kind of focus on medical. I do a lot of PRP as well. I do combine it with the 660 nanometer red light therapy. And I know that, you know, the first initial FDA cleared devices were that you held it and your arm got tired and you know, just had to hold it up there till you finish 5 minutes. However, I have the device that's kind of like, looks like a hair dryer basically in my office. And so I tend to numb my patient's scalp with topical numbing. So while they're sitting with the numbing, they also have the red light on as I'm preparing the PRP. I too use the Eclipse system. It was the first one that I really was exposed to. And in fact, myself and Valerie Calendar, who still does a lot of hair transplants, we're getting ready. We submitted a protocol to Eclipse to use the treatment and anti-inflammatory effect in CCCA. So I do currently use it in that condition, and I see a lot of anti-inflammatory response with it in addition to hair growth. And so I too, like Matt, I use vibration and it really helps. But also I think it helps, it's kind of like some of the systems want you to centrifuge the preparation twice. I just do it once because that's what Eclipse says. But I think at some point the vibration actually helps to break down the platelets as well. Another thing I do is I use the rich portion and the poor portion because I don't see, I mean, it's not like there's nothing in there. If you spin it down right, I think you can eliminate the inflammatory components, but I don't throw out the poor. But I do separate when my assistant draws up, I separate the PRP from the PPP, and I inject the rich in the main focus areas and the poor in the periphery. So I really, like Matt was saying, there's no regimen or protocol to how this is done yet. And I don't really see it forthcoming because the FDA doesn't really have a claim over it because it's the person's own blood that you're working with. And, you know, there may be individual genetic factors to why they respond better than the rest. But I would say I have well into upper 90% as far as response. And that's with one treatment. So I tell patients, that I'm going to treat you this one time, because I've had patients to come to see me who have been other places and they say it didn't work. I'm like, well, it depends on how you were injecting. There are a lot of factors involved. There are a lot of people out there doing this procedure, not injecting in the follicular, plane. They're floating it in fat. They're doing all kinds of things for a money-making venture in their practice. So you really do, I think dermatologists need to own this, because we're used to intralesional injections. We're used to knowing what the depth is. You used to know where you are when you inject into fat. So I think all of those factors I take into play when I'm injecting, and I have great results with one treatment.
That's really interesting that you're combining your injections with red light therapy in your office, because that really dovetails with my last question. And I'm going to pose it to Reena in terms of what red light systems and caps do you recommend to your patients and why? And then really how prevalent is that, in your practice, that people are willing to do that?
Well, I think there are a handful out there. There are a lot of good devices out there. For a while, we were carrying the Theradome helmet in the practice, and it's a great low-level laser therapy. I think, it has the appropriate wavelength. It's not red light, it's actual laser technology, and it has a good number of laser units. It's a very ugly helmet, not super comfortable or anything like that, but I felt like it was a good price point, about $900 or so. So I do recommend that one. We don't carry it anymore, but I do still recommend that one. I like the Capillus a lot. I think it's very sleek and very comfortable. And I think that patients like that. And if they're very tender headed, and if that's going to be a barrier to use, then I think the Capillus is probably going to be a better approach. Back in the day, we used to recommend the comb, and I think that's very cumbersome. So I think at the end of the day, it's best to get something that's relatively hands-free, so a patient can multitask. You can do it while you're checking emails or while you're washing dishes or whatever you want to do. And I do think that there are a good number of patients who try it. When they come to see us, though, most likely they're going to be doing it along with or as an adjunct to other therapies. They're probably not going to leave your office alone with just that as solo therapy, although it is a great option for solo therapy in a patient who's potentially trying to conceive and doesn't want to be taking topical or oral supplements. So I think that that's something that they can continue even, after they become pregnant, with probably pretty minimal risk. And then, so I also like the Hair Max headband. I think that that's kind of a nice one that they can move, and it's very quick treatments. And so anything that will increase compliance, I think, is a good one for home use. We don't do the in-office red light therapy at the moment, although I've thought about bringing it in. We just, right now, I don't think I have room for it, but I do think that it's a great thing to offer patients.
Well, so Mark and Cheryl, do you guys sell any units in your office as far as caps, and or what do you recommend to your patients as sort of a combination therapy as far as caps and light and laser?
I have a Capillus unit as well. They do offer that to the physician's office to get it at a discount, so you can sell it for a little bit of a profit. But it's kind of bulky, and we just don't have the storage space for it. But I will give the patient the information to, order it on their own. And I believe they set up something where if it's from my office, they get a little discount or something like that. But a lot of people kind of don't want to be bothered with it. I tend to just stick with it in the office, and they'll get it. I have some patients coming in once a week for it. I charge, for them to come in for it. So it's almost like a separate room where they can go. It doesn't tie up one of my exam rooms. And so I set it up in that fashion, but they are able to purchase it.
And Mark, what about you?
One of the, all that's been mentioned, we mentioned patients, and one additional one, there's something called Laser Cap company. And the way we do it is people order it, that the companies have a model where they sell through the physician office. So they'll call us, order it, and then the company will FedEx it directly to their home. So they don't ever, if they want to come in, pick it up, great. Most people these days would rather have it just delivered right to their home. And I'm a huge believer in synergy between these. There's studies that show synergy between different products. I always tell people I am a dermatologist, and we often use combination therapy to treat acne and other skin disorders. Hair too, I tell them the biggest jump is from 0 to 1. Do one thing, consistently. That's the big thing. But if someone says I'm motivated to do 2, I do believe there's synergy, and there is some published data supporting that, and certainly a lot of anecdotal evidence too that there's synergy between the 2. And laser's been popular. I think laser a lot of times I find is personality driven. If somebody's like, you know what, I can do my emails, I'll wear my cap, I can do it. So I almost kind of enjoy it. And then there's the other person who's like, I'm out every night in New York, before the pandemic, I'm never going to wear it. I travel, then the cap's not for you. Do PRP. So, or do the Propecia or Rogaine. So a lot of it depends on personality and lifestyle.
So, and is there anybody doing anything novel in your office that we didn't talk about? For the patients who don't seem to respond to PRP, and Marc, you talked about, maybe that's about 30% of people, and for those people, are you offering anything else? We just started doing Carolace, which is using the Lutronic Lace MD with a different type of handpiece, a 1927 laser, and topically applying Carafactor, which is something that Amy Taub and some others have been involved looking at specific growth factor products that have been synthesized in a lab, which is a Korean-based product. Is anybody doing anything like that in your practice for somebody who may not respond to PRP or want something different?
I have that in my practice as well. I was kind of like the sub-investigator for Amy when she was testing it with the hydrofacial device, and then using the Carafactor. Patients who are on the fence on starting PRP, I will offer them that. But I find after the PRP, it just is a great adjunct therapy. And so everybody, I may even include it into the price that they take that home. I don't believe that's why I see an improvement in one treatment, because before I had it, I did everything pretty much the same. But I think when you have patients doing something at home, they are more involved in their care. And I don't think it harms them in any way. I think it does help.
Well, honestly, thank you all three very much for being a part of this exciting panel, talking about hair loss and how we treat it and things that we all as dermatologists see every day in our practice. And we appreciate all of you joining us for another episode of Scientifically Speaking.